Good day, everyone. Welcome to session 2 on day 1 of TIO. And really, we are here. This session's update on opportunities in transcatheter edge-to-edge therapies. I'm delighted to be joined today by a really esteemed panel from all around the world, each one really a leading expert in the field of transcatheter structural heart interventions. And let me introduce them to you one by one. So first, Kendra Hub from Emory in Atlanta. Welcome, Kendra. Then we have David Hildig-Smith from Brighton in the UK. Holger Thiel from Leipzig. And Lars Sondergaard from Denmark. Thank you all for joining us. I think it's a really exciting session we have today. We have 3 talks, and then we're going to go into some live cases. But before we get started, I want to really encourage the audience. We have a mechanism for you to give your questions. We have a whole team of physicians who will respond to those questions online. So as the talks go on, please submit your questions and we'll try and respond to all of them. Before starting with the first talk, we do have a poll that I'd like to introduce, and I'd like to encourage you to respond to the poll. So here it is. We can bring that up on the screen. So our poll is, the question is, transcatheter edge-to-edge repair, or TIR, as it's now being called, particularly here in the United States, for functional mitral regurgitation in the context of heart failure with reduced ejection fraction should be used only per COAPT criteria or more liberally than the COAPT criteria. So either A or B. If you could respond to that, and I'll share with you the results of the poll a little later. So without further ado, I'd like to get into our lectures today, and we're going to start first with Holger Thiel, who's going to provide us with an overview of the commercially available technology.
Yeah.
Thanks.
Yeah, dear Sam, it's a pleasure for me now to present an overview of a commercially available technology for transcatheter edge-to-edge repair for either the mitral valve as well as for the tricuspid valve. As you can see it here, this is the timely evolution of TIR technologies. And as you can see it here, from 2008 to 2018, so for more than 10 years, we only had one device, which was the MitraClip. And in 2018, the XTR device has been introduced. And since 2019 and now 2020, we have more and more devices with more and more options, as you can see it here. In 2019, the Pascal device has been or has gained CE mark in Europe. In 2020, we now have the TriClip device. We also have the Pascal ACE device. And as you will see also, we now have the generation 4 for the TriClip device as well as for the MitraClip device. Also for respect to clinical trials, you can see it here. We have trials. We have the Everest trial, the Everest 2 trial, the randomized trial in patients with primary mitral regurgitation. And then later on, we have the 2 large-scale randomized trials in functional mitral regurgitation, where, as you know, we have profound prognostic impact in functional mitral regurgitation, as shown by the COAPT-HF trial. What we also know is the procedure is safe. It is has a high procedural success rate, now coming closer to that what surgical results are. And we also have an improvement on functional status and quality of life. However, in comparison to that what has been a success based on clinical trials, so reducing mitral regurgitation to a grade 2 or 2 plus, this is not what we are aiming for nowadays. So we are more aiming to trace or no mitral regurgitation. That's the reason why we need better devices for individual patients where we have more complex anatomy. And this is what fortunately we now have with the technology available. So as mentioned in 2019, the Pascal repair system has been introduced. First of all, we also had to learn new words. We were not talking about arms and grippers anymore. We now are talking about pedals and also clasp. And more important, as you can see here, there's a spacer, which allows probably to reduce more the mitral regurgitation in these patients. So next device also with the evolution is the MitraClip generation 4, which is also a novel device. First of all, as you can see it here for the mitral position, we now have also the XTW device, which is wider than the NT device. And also important, we now have the possibility of independent grasping of the leaflet, but we can still use the simultaneous grasping, as you can see here. So with respect to the tricuspid valve, it's more complex. So first of all, we have more dense chordae, then the leaflets are much thinner and very variable. And more important also, we have a large annulus, and according to this, we have huge gaps currently, in particular in patients with severe torrential or massive tricuspid regurgitation, which is more a challenge also for the devices we are using. So, as mentioned, in 2019, we now have the TriClip system, which originally we started using the MitraClip device in the tricuspid position already in 2016. But then we have now technical iterations. And as you can see, we have very important knobs. So the septal to lateral knob, as well as the extension and flexion knob, which allow us to better steer the system during the procedure, as you can see it here. So we can align for the septal, or we can correct for the septal hugging, and which allows us to approach the tricuspid valve in a 90-degree fashion, which is mainly the advantage of the SL knob, as you can see here. Then we also have the Pascal device, also for the tricuspid position, as you can see it here. With this, we have more flexible and also some passive grasping of the leaflets. So you can compare the Pascal device maybe to the TriClip device more. One is more a screw, and the other one is more a spring. So as you can see it here, this probably allows us to also have more a more atraumatic device due to the flexibility of the device, as you can see from this movie. With the Pascal, we have independent leaflet grasping, as mentioned before, which is extremely important. As you can see it here from the movie. So this is an animation where you can see that you can first grasp the septal leaflet and then make a turn over to the anterior, or maybe the other way around, just to grasp both leaflets. And in clinical practice, you can see it here. So anterior leaflet grasping, then the so-called Tarzan maneuver, then you move over to the septal leaflet, and by this you can grasp both leaflets and have a nice adaptation of the gap of the tricuspid regurgitation. Newly introduced is the Pascal ACE implant system, which is less wide than the original Pascal system. It has only 6 millimeters, as you can see it here. This is how it looks like. So just to mention it, so 6 millimeters is exactly the width of the TriClip as well as for the MitraClip device, the XTW. So with this, we have more options to treat patients, either MitraClip as well as in the TriClip in the tricuspid position. Very recently, CE marked the TriClip Generation 4, which maybe give us more unlimited options. As you can see it here, CE approval has been granted on the 8th of April 2021, so only 1 week ago. And with this, we also have the option of the XTW, the NTW, and we now also have the option for the tricuspid regurgitation that we can use simultaneous grasping as well as independent grasping for the patients. And with this, I would like to finish my presentation. I'm looking forward to the discussion and to the question and answers. Thank you.
Thank you, Holger. That was a great overview of the two devices that are now available for transcatheter edge-to-edge repair. Maybe I'll start with a question to you, Holger, and let's stick to mitral first, and then we'll go to tricuspid a little bit later. So, we've had these two randomized trials, and you briefly mentioned them, and I just wondered what impact these trials have had on European practice. I'll ask Kendra to comment as well after that on the impact it's had here in the United States.
So at least what I can say for Germany, we adopted to use the MitraClip device in the mitral position, in particular for functional mitral regurgitation, already before we had the two randomized trials. And based on this, the change after the release of the two randomized trials was not so big. Nevertheless, we have more and more centers nowadays performing mitral interventions for mitral regurgitation. And currently, at least what I know, based on the data we are currently doing more transcatheter mitral repair interventions than surgical interventions. And this is probably something which is also remarkable.
That is remarkable. I didn't realize that there were so many transcatheter interventions. Kendra, maybe if you could briefly comment on the larger impact COAP has had here in the United States.
Well, I too think that we're seeing many more centers doing MitraClip on functional mitral regurgitation. But with the two trials, I think we're being more critical of the patients who we are implanting these clips in. I think before the trial results, we would often find quote unquote mixed patients, and we weren't as critical as we are now. And I'll get into some of that during my presentation, but certainly there are patients who are not going to benefit from a clip, and we're starting now to really learn who they are.
Lars, we now have so many choices. Just when you look at the mitral clip, we now have 4 mitral clips to choose from. So I wonder if you comment for the audience, how do you choose, very briefly, what's your algorithm for choosing one clip versus another in your patients?
Yeah, I mean, the XT was certainly an improvement. You have longer arms, so it's easier to make your graspings. And also now with the XTW, you have wider, so you can often have less. So I think that's, for me, will be the first choice. The patient where we would consider to use an NTR clip will be patient who are at risk for mitral valve stenosis, afterwards small annulus. And also if you have quite short posterior mitral leaflet where you don't have sufficient tissue to actually to grasp. But I think those is probably the two most important reasons to choose a smaller clip. But I would say the first choice and the clip for the most of the patient will be an XTW.
Thanks, Lars. Holger, if I can ask, here in the United States, we only have MitraClip commercially available. Pascal's only available in the context of a clinical study. You now have both devices on your shelves. You have a lot of choices. You've got 4 clips for the mitral, plus now 2 different Pascal devices. How are you choosing? I mean, can you help us a little bit? Which patient is better suited for a clip versus a Pascal?
Yeah, difficult question. So we currently, if you ask me, it's very similar to the TAVR procedure. Maybe for 95% you can use either device, and but there are probably maybe 5 to 10% of patients where it's more complex, where you have more complex anatomy and where you have to decide. So in particular for the tricuspid regurgitation, I think it's very important to have the independent grasping of the leaflets. And for this, if you have a wide gap, in this particular situation, the Pascal device probably is better than the original tracted device. So this is something where I would consider the Pascal device as a better option. Coming back to the mitral position, I think it's also very important. If you have huge mitral regurgitation, sometimes the Pascal device may be better. And currently, nevertheless, we do not have randomized data on this. We are waiting, as you know, there are ongoing randomized trials, and hopefully these will give us more answers on when to use which device in which situation.
Thanks, Olga. Kendra, do you think any of these devices are better suited to the tricuspid? And do you see edge-to-edge therapy as growing for the tricuspid valve as a future therapy?
I certainly do. I know, with no really great surgical option for many of these patients, I think that we have to start, one, treating patients earlier, but two, offering some of these therapies. In terms of which device, I can't yet predict, but I know that we're still on a very steep part of the learning curve.
Thanks. My last question, Lars, to you. You now have all these devices commercially available for the tricuspid. Here in the United States, we can only really do it in the context of a clinical study. How has that impacted your practice, Lars? In Denmark, are you doing a lot more tricuspid clipping now than you were a year ago?
I mean, it's still very new that the TriClip has been approved in Denmark. So the case that we did in the past was with the MitraClip, which of course was a little bit challenging. But there's a lot of interest in this and a lot of awareness. So we can certainly see the numbers going up, but still we don't see, how should I say, German numbers. But there's certainly awareness about this therapy.
Great. Thank you. I'd love to move on. I think we hinted already that edge to edge is just one of the devices, and patient selection is really important. And we probably need more than one device to treat patients with functional MR. So Kendra, maybe if you could take us through how we decide which device for which patient.
Well, thank you. Well, thank you. And I'm not sure that I'm going to have all the answers for you. I think we still have a lot of questions, but I will try to discuss transcatheter treatment options for functional mitral regurgitation, which device for which patients. So just to remind everyone, we're talking about functional regurgitation or secondary for this presentation. And this is a disease of the ventricle or the atrium. And so what we had been talking about was leaflet technology, and whether or not that's going to give us a durable result when the problem is the ventricle still remains to be seen. And when we think about the Carpentier classifications, oftentimes we are classifying the mitral regurgitation in terms of surgical ability to repair these various pathologies. And specifically for this presentation, we'll be focusing on type 1 and type 3B. The guidelines currently have secondary mitral regurgitation with goal-directed medical therapy as being the first step. for functional mitral regurgitation. And then for those patients who have severe MR and are undergoing CABG, then the recommendation is to proceed with mitral valve surgery. And here you can see that edge-to-edge repair is really for those patients with a reduced ejection fraction and persistent symptoms, and then appropriate anatomy for the clip. So very large ventricles are going to be excluded from this. And if surgical, most of these patients are going to undergo mitral valve replacement. I apologize. Currently, the FDA approved MitraClip and CMS covered, as well as the guidelines for only TEER is reasonable for severe secondary mitral regurgitation, as long as the patient is on optimal goal-directed medical therapy. For those patients with New York Heart Association class 2 to 4 and an EF of 20 to 50%, again, with appropriate anatomy. But what does this clinical evidence tell us about who benefits most from TEER, and how can we apply this to our daily practice? Well, who benefits most from the clip? Well, it turns out that patients who are older, patients who have depressed LVEFs, and those with functional mitral regurgitations, those patients were identified as having the benefit based on a subgroup analysis from Everest. This is the COAPT data showing excellent durability at 3 years. I apologize, the slide is not projecting properly. The MitraClip device, as mentioned previously, is now in a 4th generation, which was available in 2019 and previously described. A wider version, as well as longer arms and independent grippers. So which patients are not suitable for clip? The outcomes are more dependent on suitability of valve anatomy to the clip itself. So small areas with gradients greater than 4 at baseline, massive EOAs with a jet that goes across the entire line of coaptation, rheumatic disease, stiff, thickened leaflets, and immobile leaflets or cords, and Barlow's valves tend not to do well with this technology. And some anatomy is not favorable to TEER, such as posterior leaflets too thickened to grasp. And here demonstrated are some examples. Immobile posterior leaflets, a P1 scallop, a small mitral valve area with severe MR, or a dominant jet that's lateral. And these are difficult to clip using the MitraClip system. Also a reminder that severe RV failure patients typically do not do well. As mentioned previously, we now have a second device in trial in the United States with the Pascal trial and the CLASP trial, and the Pascal device, which was previously described, with a spacer and paddles. And it may be that the spacer is able to increase our ability to grasp leaflets that have a wider coaptation, or excuse me, a wider gap in the coaptation. Here demonstrated is the Pascal device with the center spacer to bridge the coaptation gap, elongation of the device to navigate dense chordae, and the nitinol frame, very different than the MitraClip device, and independent graspers. And the previous presenter mentioned the ACE, and so I will not go over those specific details. With what we know currently, very short-term data, excellent survival and freedom from rehospitalization at 1 year with the new device. And here are some before and after pictures with reduction of MR. What about transcatheter mitral repair? Well, it turns out most of these devices have been trying to mimic surgical repair. As a surgeon, I would never just go and do an Alfieri stitch. I would put a ring or do multimodality repair of mitral regurgitation. And although this is described in degenerative MR, I do wonder if there will be combined modalities addressing either the annulus or at the ventricular level for functional mitral regurgitation. And this moves us on to the replacement techniques. I won't belabor these, but we have various valves that are in trial in the United States. The Tendyne is now in a pivotal trial. And here you see a large valve. It's a D-shaped valve, so it matches the anatomy of the mitral valve. And it's a transapical access with an apical tether. And so this device is now in pivotal, as demonstrated, as depicted here, as well as an arm specifically for MAC. Intrepid is a conformal outer stent, which then interacts with the annulus, as well as has the barbs, with a circular 27mm valve on the inside. And this valve is also under pivotal trial. Initially a transapical approach with a plan for transseptal. Again, demonstrated some examples of the valve once implanted. Some comparisons between the two trials. The delivery catheters are both very large, 36 and 35 French. The Summit trial with the Tendyne valve is controlled with MitraClip, and Apollo, or the Medtronic valve with mitral valve surgery, soon to be switching to MitraClip. Additionally, Edwards valve, Evoke, another valve frame with a different design, with an interannular sealing skirt and a valve within this frame that has the outside graspers in order to seat the valve in the annulus. And this integrates the Edwards bovine pericardial leaflets and comes in 3 sizes. Interesting, this is the delivery system, which is lower profile, 28 French. It is a transceptable, steerable delivery system. And that potentially means we wouldn't have to close the transseptal puncture. There's a stabilizer system for increased control and flexion in multiple directions for precise positioning. There are many valves available to us for trial. However, none of them yet are commercially available in the United States. And there are some challenges to transcatheter mitral valve replacement. The valves are high profile, and often we worry about LVOT obstruction. Most of the devices are transapical, and so we have to worry about ventricular access. We have issues with steering and managing devices transeptally and avoiding pinning leaflets of the anterior mitral valve. Malpositioning and postoperative heart failure also make these valves challenging. Thank you.
Thanks, Kendra, for the great presentation, overview of the devices. So I'd maybe like to use that to ask all 3 of you to tell me a little bit about, when you think about functional MR, what's currently in your toolbox and what's missing. I mean, because right now it seems for a long time all we've had is edge-to-edge therapies. But you just mentioned, that possibly we need more. Certainly, Kendra, you as a surgeon, when you go into, as you mentioned, to surgery, you have all these different options. You can put a ring in, you could replace the valve if needed, you can work on the cords. So, I mean, do we need to have similar approaches when it comes to transcatheter therapy? So, Lars, maybe we'll start with you. What's currently in your toolbox? What do you wish you had in your toolbox if you don't have it now?
Yeah, but I mean, as you said, the surgeons have different ways to approach it, both the leaflet repair, annuloplasty, and chordal replacement. For transcatheter approach, it's completely dominated by edge-to-edge repair. The other treatment, patients treated is very small numbers. So I think we need to move forward on this and have better devices, better optimized procedures. And I think it's going to be very important also to have the possibility for valve replacement. Still, unfortunately, the Apollo trial is not going to have this edge-to-edge repair as a control group, and I think it's going to leave it in a limbo. Is it becoming an alternative to edge-to-edge repair, or is it only for patients who actually cannot be treated or is predicted not to have a good outcome with the edge-to-edge repair? So if you ask what I need to see more data and on these devices.
Thanks, Lars. Holger, Leipzig is always at the center of innovation and new devices. What's the approach in Leipzig? Do you have other devices to offer patients who are not ideal candidates for edge-to-edge?
Yeah, so as mentioned also by Lars, I cannot echo it more. It's dominated mainly by currently transcatheter edge-to-edge repair. Nevertheless, there are options like the cardioband, which in some cases you may also be able to combine or with the transcatheter edge-to-edge repair. So more reflecting this what the surgeons are doing, but we are only doing this in really very, very selected cases, and in particular because also reimbursement issues play a role if you are combining two different devices, which are usually not so cheap, and that's the reason why you really have to consider when you are doing this. I know some centers, not our center, which are using the Carillion device and combine it sometimes with the MitraClip device or maybe also with the Pascal device from functional mitral regurgitation to also have an annuloplasty. Honestly, we do not have vast experience with that, and that's the reason why we do not use it.
Yeah. Thank you. Thank you for mentioning annuloplasty. I think transcatheter annuloplasty is an area that's growing. You mentioned Cardioband and Carillon. There's also the Millipede device that's going into clinical studies, both here in the United States and in Europe, and I think hopefully will give us more data on using transcatheter annuloplasty for functional mitral regurgitation. Kendra, I think everybody's mentioned about how edge-to-edge repair is the predominant therapy, but I think all of us here who've done it have realized that it doesn't work in all patients. And I think you both showed some anatomies where potentially an edge-to-edge may not be as good. Certainly, there's now documents even coming out soon trying to delineate what's a good anatomy. So almost having the green light, of patients who will get a good result versus, the orange light, the yellow light, and then the red light of anatomies we shouldn't be treating. You mentioned replacement. I mean, some advice about, what kind of patients you think are better candidates for replacement versus edge-to-edge repair. What are those patients who are in the red category for an edge-to-edge repair?
So the patients who I think are in the red, that are the obvious ones, I mentioned briefly, the restricted posterior leaflet where you're just not going to get a good grasp, shortened cords. Those are going to be patients where you may be able to initially get a clip on both leaflets, but are you really going to have a lasting result? I think very large dilated ventricles, those are patients where we've seen already that those are not good candidates. And then the patients that have a coaptation gap that the clip either is not going to reach or barely reaches, you have a jet that comes across the entire coaptation plane. Those are going to be patients that we really need to be thinking about a different modality. And the reason I mentioned when I was talking about the guidelines that most of the functional patients are going to end up being a replacement candidate surgically is that it may be that there is a difference when you're talking about degenerative or functional MR, and we need to be using different devices for the different pathologies.
Yeah, absolutely. And there's another group of devices I've seen recently for functional MR, and certainly they've started studies in the United States and Europe. So they're these posterior leaflet technologies. So you showed this case, one of your echoes shows a patient with severe posterior leaflet tethering. So there's a company called Polaris, there's another company called Half Moon, looking at replacing the posterior leaflet and creating a larger coaptation zone. And as a surgeon, does that make sense to try, instead of replacing the whole valve, possibly just replacing the posterior leaflet?
I think it's worth trying. Most of these patients we are not operating on now. And so if we can offer patients a durable result, I think it makes sense to try that. Again, if it's a ventricular problem, we should also be looking for a ventricular solution.
Well, absolutely. We've spoken a lot about mitral. As we shift, I wanted to shift a little bit to tricuspid as we get to the next presentation. And certainly we've seen for mitral how edge-to-edge has dominated, and the valves have taken a much longer time to grow and to enroll in the clinical studies. When it comes to tricuspid, we're seeing a flurry of both repair technologies as well as replacement technologies. And I wondered, to ask, maybe starting with Holger or even Lars, your thoughts about tricuspid valve replacement compared to repair as this field continues to grow.
Yeah, we've been better in doing edge-to-edge repair in the mitral position, and we aim to have not more than a grade 2 mitral regurgitation. In most of the patients, we can have an even better outcome. I think if you look at the tricuspid valve, we have huge coaptation gap in the patient coming forward. And this patient is often left with much more tricuspid regurgitation after an edge-to-edge repair, despite it's an improvement from baseline. So I think replacement could be even more important in the tricuspid position than in the mitral position, at least as long as we cannot, until we potentially can improve the outcome for edge-to-edge repair in the tricuspid valve. So I think replacement could potentially have a greater role in the tricuspid position than in the mitral position.
I cannot
Holger?
echo this more. If you ask me, probably also tricuspid valve repair is probably, in particular for patients with massive or torrential regurgitation, a very good option. And because we do have less problems with large bore excess, I personally believe if the devices are CE marked and if they have shown that they can work, this is a very good option, in particular for patients where we estimate or we believe that we will have a suboptimal result after transcatheter edge-to-edge repair in patients with tricuspid regurgitation. If you ask me, this is a huge opportunity to have valves readily available for patients with tricuspid regurgitation.
Completely agree, Olga. I'd say, here in the United States, where we have a number of clinical studies looking at repair and replacement, the replacement studies are enrolling incredibly quickly, and we've all been surprised to see how well they've been enrolling. Holger and Kendra, I wanted to thank you for your great presentations, and I wanted to let you go because I know we're going to be joining you in a few minutes for the live cases, so I'm sure you need to get your teams ready and prep for those cases. So thank you for the presentations, and we'll see you live in about probably 15 minutes.
See you soon.
Thank you.
Thanks. See you.
And with that, we'll go on to the last one. Great. So I wanted to talk to you about really step-by-step, take you through an edge-to-edge repair for tricuspid regurgitation. Now, many of you have already seen mitral clips. Either you do them or you've seen them presented at meetings or being performed in your hospital. And I think, the mitral clip procedure or the transcatheter edge-to-edge repair procedure for the mitral valve has gotten to a stage where it's really the imaging is known to everybody. It's become very predictable. We all know the views that you need to have in order to perform the procedure. But also, we've learned over more than 100,000 procedures who are the better candidates for this technique. When it comes to the tricuspid, we're also learning, and I think it's important to start becoming familiar with some of the imaging you need during these procedures and who are the best candidates. So I'll try and take you through that. These are my conflicts of interest. So, we look at the TriClip device. It's a little bit different from the mitral device. As you can see here, looking at the knobs, and as mentioned by Holger, there's a separate knob on the guide catheter. So there's a knob that gives you the septal lateral movement, because we've learned with tricuspid, depending on where the inferior vena cava comes into the right atrium, as you turn down to the tricuspid valve, you may find yourself really hugging the septum and not being able to be coaxial. There's also some minor changes to the tip of the catheter. It's got a shorter radius of curvature, which allows you to be higher up and not cross the tricuspid valve immediately. But as far as the clip is concerned, whether it's the TriClip or it's Pascal, the actual clip device that goes into the valve is identical for both the mitral and the tricuspid. Now, the imaging is different. It's more challenging. The leaflets are thinner. They may often be shadowing from other structures, such as mitral valves, aortic valves, rings. And also remember that the tricuspid valve is the most anterior valve in the heart and the furthest away from the esophagus. And so it can sometimes be a challenge to get good imaging. So when we think about who's a good candidate, the anatomical features we think about, the mechanism, how big the gap is, are there leads, where the leads are. There are also some patient issues. And we will often not do a procedure if on the pre-procedural workup we see we don't have good TEE imaging. That might be a reason for us to say that we'll not do the procedure. Because really the key to this procedure is TEE. And that's why during this presentation, I'm not going to show you a single fluoroscopic picture. I'm only going to be showing you TEE images, because I really do believe this is the way this procedure is guided, and it's the only way to really get good at tricuspid edge-to-edge repair. I didn't want to highlight this paper by Jorg Hausleiter, and many other of us contributed to this. If you're trying to start transcatheter edge-to-edge repair with TriClip, I would suggest you look at this ideal group on the left. Those are the patients you want to start with. Those are the easy patients. Don't go for the patients who are more difficult, who have quadricuspid valves, the patients who have leads, who are maybe interfering, or with large coaptation gaps. Choose easy patients with good imaging. So let's look at some of that imaging then that you need to know. Here's my patient, a 73-year-old male who had severe TR, probably atriogenic from long-standing atrial fibrillation. This is functional TR. He's also got an ischemic cardiomyopathy that, with pulmonary hypertension, that probably also contributed to his TR. So probably two mechanisms. He's really on full guideline-directed medical therapy and has multiple comorbidities. Not a great patient to undergo surgery. So we enroll, let me show you his pre-procedural imaging. And really, I want to take you through, I think, the most important images you have to learn are the RV inflow-outflow view, which you're seeing here, and then the transgastric view. So on the RV inflow-outflow view, you see on the top picture on the left, you see the aorta, which tells you where anterior is, and the other side is posterior. And really, you start with this view, and you're going to explain across this view to see the different areas of your leaflets. Now, this essentially is what is our intercommissural view when we do a mitral, when we get our LVOT view from the intercommissural. This is basically the same thing for tricuspid. It's your starting view to really interrogate the valve and understand the different leaflets. So if you see where we currently are, in this patient actually had a quadricuspid morphology, so we're in the center of the valve, in his lateral or second anterior leaflet. And as we cut across there on the right, you see the septal and lateral. We'll now move the X-plane line further towards the aortic valve. And as we go further towards the aortic valve, we now have on the right septal and anterior. If we move it further away from the aortic valve on the other side, on the left picture, we'll then have septal and posterior. So once again, this is probably one of the most important views if you're going to be doing tricuspid clipping, to really understand where the lesion is and where you want to put your device. Then the next picture that's extremely important of view is a good transgastric view. The transgastric view allows you to understand the pathology. It allows you to understand the coaptation gaps. It allows you also to understand the morphology of the valve. As you see in this case, this patient has a quadricuspid morphology and probably 2 anterior leaflets with a small posterior and a septal. And you see most of the tricuspid regurgitation or jet is coming from the center between the septal and those 2 anterior leaflets. And that's where our target's going to be. You also need this view in order to be able to orientate the clip towards the leaflets and be able to grasp. The 3Ds can also be useful, but they're not always as clear as the mitral 3Ds. So whereas on the mitral side, you might use the 3D to get your your clip orientation. Here with tricuspid, we get our clip orientation really predominantly using the transgastric view. So essentially, the inflow-outflow view is your main view for orientating as well as your transgastric. So this is how the procedure starts. We get a wire that goes up into the superior vena cava. In this initial part, we use a bicaval view. You then, over that wire, will advance your delivery system, your guide catheter. Once you remove your guide, you'll then insert your clip, being careful not to go towards the septum and to direct your clip towards the superior vena cava. And so this first part's all done in a bicaval view. Once you see your clips inserted, you can see the septum, and if you look at 6 o'clock, that's your tricuspid valve, and that's where you want to steer to. So you're going to steer away from the septum towards the tricuspid valve that's at 6 o'clock. Once you start steering towards the tricuspid valve, you then will start using other views. You'll go to either your RV inflow view or 4-chamber view just to make sure you're starting to look down towards the tricuspid valve, and then you'll start optimizing your trajectory and orientation towards the valve. So here again, just reminding you, this is our most important view, right? This is the RV inflow-outflow view with the aorta showing you where anterior is and posterior, that's on the left. And then depending on where you move your X-plane line, you'll either be seeing the posterior and septal leaflet or the anterior and septal leaflet. Here we decided we were going to target the anterior and septal first, and so that's what we targeted. Another view that I think you need to start getting familiar with, both for mitral and tricuspid, are these MPR views. The multiplanar reconstruction is basically allows you to, off your 3D, really reorientate your planes like you would with a CAT scan on the valves. So even in patients with more challenging anatomies or horizontal hearts, you can sometimes use this to overcome more challenging imaging. And again, we're always using the same views. On the left, you have anterior and posterior, and you X-plane over, and you cut over that to get, on the right, septal, always on the left, and then either anterior or posterior. So here we were, like I said, targeting anterior and septal. You can see now we've orientated the clip correctly. We really like using these 3D MPRs because in one view we can grasp, plus we can maintain and check the orientation of the clip as we move down through the valve, that we don't lose the orientation. So here we've placed the first clip on the anterior and septal. I think one other important thing that I'd like to highlight compared to mitral, so in mitral, we always, if we're going to do multiple clips, we prefer starting medial and going lateral because it gives you more maneuverability. When we do tricuspid, we like starting at the anteroseptal and putting our first clip there and then moving posterior. And the reason being is because if you don't do that, you can get shattering from the delivery system and from your first clip. So now that we've put the first clip between the anterior and septal leaflets, we'll now start moving posterior to grasp the more, either in this case, the septal and lateral leaflet. Again, yeah, just showing you these 3D MPR views, I think it's important to start familiarizing yourself with how to use 3D MPR, particularly as you start moving to the tricuspid valve and want to do procedures on the tricuspid valve. And so here we're clipping the septal and lateral. That's our confirming leaflet insertion. And here's our second clip going in. I'll show you the final result with really an excellent final result. So I think when it comes to tricuspid, it's different imaging. But really, you need to work well with your imager again to understand well the anatomy, the morphology, and the language you use, so you're using a common language. Good imaging is really essential for the tricuspid, and you really, if you see you have suboptimal imaging on the screening, you probably shouldn't be doing that case, especially not as a first case. As you get better, there may be adjunctive techniques you can add, such as TTE and ICE, and you really need to sometimes adapt on the fly. So I think this is really doable to learn how to do tricuspid edge to edge, but my final advice would be start with easy cases with good imaging so you can learn how to do procedures on the tricuspid valve. Thank you very much. Lars, I see Nicholas has joined us too. Good to see you, Nicholas. So I try to give you some step-by-step on how to do tricuspid edge-to-edge. Lars, you have a lot of experience with ICE as well. Do you think that ICE is going to be useful in doing tricuspid procedures?
I know that quite a few sites are using ICE to guide it. I would say it was an excellent presentation here, Asim, as always. If you know how to do mitral edge-to-edge repair, I think you can, there's a lot of things which is similar on the tricuspid valve, despite the terminology and so on is different. So if you're used to do edge-to-edge repair in the mitral position, I would certainly start out also using TE in the tricuspid for the tricuspid valve, and then you maybe down the line can try to see whether ICE is going to provide additional information.
Right. Yeah, I think it's really important to do for the tricuspid what we did with the mitral, is really to standardize it and break it down into the different steps with the imaging you need in each step, right? And so with mitral, we've done that, and I think we now can do that with tricuspid. There's always going to be the challenging case where maybe you need to adapt and change, but I think we're getting to that stage where you can say, in the beginning, you go to transcaval, then you go to this inflow-outflow view with your X-plane, and you'll use your transgastric to orientate, and then come back to the inflow-outflow to grasp. So that kind of systematic use is really important. Nicholas?
Yeah. So also I would agree, this was a superb illustration of how to approach step-by-step a tricuspid repair with catheters. That said, to respond also to your first question on the use of ICE, when we started our TR repair program, we thought that this ICE catheter really gave us superior imaging of the tricuspid valve. And that was not surprising, of course, because there is no far field with an ICE catheter at the level of the tricuspid valve itself. So you get a very good appreciation of your leaflets. But I must say, as we are improving and doing more and more TR cases, we no longer use the ICE catheter, because also the learning curve with the TEE is more or less beyond us. So I think TE probably will drive these procedures for the foreseeable future.
Thanks, Nicholas. We're going to go to Leipzig in a sec. I just wanted to give you all the results of the poll. So we asked you earlier about who are the kind of patients we should be treating with transcatheter edge-to-edge repair. Should we really stick to COAP-like criteria, or should we go beyond the COAP-like criteria? So if we could have the right poll results on, that would be great. I think this is the previous one. and I'll give you another few seconds. If not, I don't want to cut away time from the live cases that are so important. So why don't we just switch to the live cases? Let's go live to Leipzig, who are waiting to show us a transcatheter edge-to-edge procedure.